Today I'm doing a refinement of a refinement. It's a tricky one. Mandibular midline of 1.5 millimeter, expansion maxed out during the first 2 sets of aligners, and no room for distalization because there is partially erupted wisdom teeth. I'm going to share it with you step by step in real time. If you stick along, it's going to be longer than an hour, but you might catch a few ideas worth stealing. I'm Dr. Petra van der Merwe, an orthodontist with more than 30 years of clinical experience. My orthodontics is focused on aesthetics, driven by everyday function. I help dentists avoid common aligner mistakes and create predictable treatment outcomes. This is a more natural curve on the patient's left-hand side. This is not natural. The step is just too big. And I can't work out for myself where the problem is. Let's check again. I think this one is further down than that one. That one needs a bit more torque. More torque. And more. It's better. I think the amount of crown showing there, there's not symmetry in these two canines. I think that is where my problem comes. I'm going to already an improvement. Still not where I want to be. Then I think his amount of facial structure I see, it should be rotated. That is going to do the trick. It does look. Let's see. That's third order bent. It's what's getting me here. And it immediately has got a better look there. And that one is good. Okay, I'm going to play and see the movements, which is actually a lot happening there. See that bottom midline coming over. So I need a lot of movement to this side. So I'm going to make use of class 3 elastics on the. Please add class 3 elastics on the right hand side. And I would do it button cut out top and bottom, or bottom cut out, one 6 4 3. I prefer to have my elastics on the teeth itself and not on the aligner. I think that's just purely preference. I just feel that I've got more hold on the tooth directly, and I like a long cut down with the aligner onto the gingiva. You definitely have more forces. Okay. You have more forces on the teeth, in my experience. A much more definite contact point, and the patient also tells me that. Okay, so cut out on that side. Let's see what happens this side if I'm going to make use of any elastics. Start there. Need to go forward. So it's going to be a class 2. Class 2 on the left hand side. Buttons as well. There we go. That's sorted. So I don't distalize that side, which is important with the wisdom teeth in. I don't distalize on that side either. This is an overexpression of the torque on purpose, because I think I'm going to lose some torque when I retract those teeth, but I like it to have a lot of overjet there for freedom of movement for the patient. There's still some minor spaces there, and I'll ask the operator to please close the micro spaces to the front, and I will also say apply a virtual power chain as the last couple of stages. Add attachments as needed. I will review. I can't just approve this case. I'll have to review it again. So the attachments are sorted, and I just feel there's more torque on that side than that side. I've just seen that now. Am I in the final? I am. If you're used to very upright teeth, then I want to explain to you the reason for this, the mandibular inclination with the roots to the buccal, maxillary with the roots to the palatal. If you look at a patient from this view, you will see that the insertion of the medial pterygoid, you see on the bottom, and it pulls up to the pterygoid plate in that direction. So it's it's one of your muscles that close the jaw, and the direction of pull is in that direction. And that's why you have to have these teeth with an inclination like that to be parallel to the forces of occlusion that the muscles exerts on the teeth. And secondly, just go and check, as I've explained and shown in the beginning. Look at this overjet, overbite that you have, and look at it when the teeth are upright. You just don't get the same proper relationship if you don't get that inclination. Okay, so I'm going to send it in. I'm going to see what they do with my case, and then I'll review it again, and maybe I'll show it to you guys. There we go. I've set microspaces, attachments, virtual power chain. And just to maybe one last remark, be informed that we added what they did. We add lower IPR in order to avoid heavy anterior contacts, which I agree, you don't want heavy anterior contacts. Let's just see if I can open up their case design like they did it. And add that. Look at that amount of IPR they added, and and just see the restriction in the bite there. This isn't good. This isn't really, well, it's something that I'm very, very sensitive for. So, okay, maybe I forgot about this function that we have here. 3.1 and 3.2. And let's go to 29 or whatever is the final result, and just compare that with that, with that restrictive overbite, hardly an restrictive overjet and hardly an overbite. And here we've got a proper deep bite. I hope I can get it this deep. I would actually love it with extrusion. Is not always that predictable, so I'm going to work very hard to get it to that level. And then if we look at this from a front view and this one from the front view, look at the difference in the overbite. And yeah, at least I've got a bite curve here, straight bite, and I've got my curve of Monson here, which this side is present and this side hardly present. Personal preference, I like this one so much more. So let us close this, and this is my 3.2, and I am going to submit. Thank you.
A few moments later.
I got the case back for review, and I just want to quickly recap. The problem I had with this setup was that there's so much interproximal stripping, point number one, and the second was the amount of overjet that was left for this patient is for me not sufficient enough. I'm just going to get it from the back. If you want a proper stop contact to prevent relapse, and teeth can either relapse by, if they procline too much and they hit, then they procline and they splay. Or if they're too upright and they hit at that angle, they relapse that way and you get excessive crowding. So in this case, what's happening here is if we can just get the contacts there, occlusal contacts, there actually is none. Let's take that away, wrong one. So you would like to have the bottom teeth must fit on that line there, in close vicinity or actually onto the cingulum. The leading edge of the incisor should make contact with the cingulum, and that is your best contact points for stability and for function. Giving it enough overjet for protrusion to let the back teeth release, and a point where it can stop. So I'm just going to repeat it. For stability in the anterior region, you must have the leading edge of the mandibular incisor touch on the cingulum of the upper teeth. That gives you sufficient contact stability, and secondly, a deep enough overbite for when the patient goes into protrusion that the back teeth release and there's no interferences, posterior interferences. So in this case, I would like to have the stop contacts there and see what the setup is currently. It's very far away from that. So yeah, for that case, I revisited it, and let's go and have a look at the case design after I did the changes in the previous video. And let's just take it through to the end, and you can see I end up excessively, but you have to go deeper than you want to because extrusion is not an easy movement. So let's just go through the movements. And there comes my extrusion. Because extrusion is a less predictable movement, I will always over extrude. And that is what's happened in this case. Okay, so let's just go back to the review, and I'm going to put them side by side. 3.4 case design, and let's just do this one as the primary case design on this, and let's have a look. that is the amount of overjet that they gave me. This is the amount of overjet I established, much more. Secondly, they didn't completely align the midlines. I aligned them and I actually overcorrected because it's coming from that side, and I moved it over and I tried to overcorrect for movements that's not going to take place. See, my bite is much deeper. And let's get that one from the front. I would call this an open bite. The height of your overjet there, and you look at your cuspal heights here, the chances for an interference is excellent. So you need so much deeper of an overbite to come clean, to get the rise of the teeth enough in the front to release the back teeth there. Okay, and then something else. It may look as if my positioning here of the maxillary incisors is excessive. The torque, the palatal root movement of the incisors. Let's just go there and see how much with my extrusion, and then I moved it back. Excessive, but again, root torque is not something that happens easily. So this is also an overcorrection. So what I see there is most probably not going to play out in the mouth. And therefore, this extensive movement. So let's go to the final setup that I've got here, and let's go and see. There you can see the amount that the roots are torqued back into the palate extensively. I hope to get half of that, at least half of that. To get this extrusion, I made use of extrusion attachments. Let me just see why that one hasn't got one on. It is coming down. It should have an extrusion attachment as well. I provided for Class 2 elastics on the patient's left-hand side because I'm bringing the bottom teeth forward and up. And on this side, Class 3s, because the bottom teeth are moving back. Let's see what happens with the uppers. Not really. So I can use this. If I want to use a Class 3 elastic on this side, I'm just going to reconsider if it's really needed. Not much, so I'm going to remove that. Okay. Remove Class 3 elastics on right hand side. Okay, but then I'm going to need an attachment either on the 6 or the 7. Add attachment on 1/6. Okay, there's something else that bugs me. Extrusion, as I said, extrusion is a difficult movement. You have to plan it properly. So what I do, especially on the front teeth, if I want to extrude, is I will add additional torque, move the teeth down, and because of the direction of the push force, it changes the inclination again. So although the teeth are excessively torqued like that, most of the movement happens once the extrusion is done. So I want to change that, and I want the just want to see. It comes forward, comes forward, comes forward. up to number 12. Back again to extrusion, difficult. If you look at the plane of that tooth, it's horizontal, it's flat. An aligner works by pushing. There's no grip on that tooth. There's literally no grip. If you take the tooth to that last position and you look at that, the aligner can push down on that tooth, and then you can get somewhere, especially if you then in this circumstances add your attachment. So let's go back to there. The only push that the aligner has on this area is that tiny, wee tiny little bit of an attachment there. But if you have the inclination of the teeth like that. So I'm going to ask them to change this setup. It's unfortunate I can't do it myself. I'm going to ask them to change it. I want that torque to be expressed before they do the extrusion to get more predictable results. Apply the palatal root torque on the maxillary incisors before extrusion movements. Once extruded, sure, I wish I could do this myself. That's so nice of the software that I'm currently wearing. I'm totally in charge of the movements myself. So what I would like to have is, let's just go and see. It's maybe too much. Yeah, way too much. Let's just. And I'm going to take a picture here and tell them while, okay. Technically, torque is movement of the roots either to the palate or buccal, and in the bottom either to the buccal or to the lingual. That is the term we use for torque. Loosely used, it is a change in the inclination of the roots, either palatally or buccally. So, no, I'm going to rephrase it. Torque technically is when you move the maxillary roots palatal and the mandibular roots towards the lingual. That's a correct terminology. That is the correct terminology out of the textbook. Loosely used, it is a change in the root inclination either to the buccal or to the palatal. So I'm going to ask them to, using the loose term, to apply the, no, I'm going to ask them to instead of palatal root torque, apply buccal crown torque to moving the crowns forward, and I'm going to take a picture again showing them. Then extrude while extrude while dipping back happens due to force application, and add attachment to the 2-1. Okay. I just moved the teeth to that position to make sure that I can do the picture, but it's not going to be there in that position. So let me quickly review the other types of movements. Just another point that's quite interesting, and I've learned this very late in my life. I wish I knew it earlier. If you look at the long axis of the teeth, the mandibular teeth to the posterior, the roots are to the buccal, and that corresponds to your torque values on your brackets when you used fixed brackets, progressively from the front to the back. And the same for the molars, but in the bottom we've got buccal root torque, in the maxilla palatal root torque. That creates a long axis for the forces of the teeth to go. That creates a long let me phrase it properly. With that, doing it that way, the forces of occlusion goes through the long axis of the teeth. Let me just upright teeth here. If you have that tooth, the 5 there, and you have that let's do it there as well. The long axis of these teeth are straight up, almost to 90 degrees on the page here. But if you look at the medial pterygoid, which is your closing muscle, your big strong muscle that brings the jaw up when you bite closed, it attaches on the inside of the mandible, and it pulls inside to the lateral pterygoid plate at an angle. And now the teeth are upright, the angle is like such, and you get occlusion forces that does not go in the line of the force application of the muscle. And that makes a huge difference. And secondly, if you look on the screen here now, and you just go and look at, okay, now in this case, when you don't have that buccal torque that's needed on the bottom teeth, you have to have a very upright maxillary tooth to be able to get a proper occlusion there. But if you remove them, and I take all of that out, let me just see that is all here. Now you can see that you can get a very nice touch there with a minimal overjet and still proper contacts there. Okay. Yeah, so let me just check the movements. If there's anything else that I want to change, there you can see this setup was very upright, and what it does is like you can't get a proper overjet overbite as much as you change the inclination. It is just so much better. As always, before I finish, I go and check the landing spot of the teeth. I want it in the deepest point. That one is not very good. That one is not bad on the marginal ridge. That one is good. There we can change a little bit of this tooth. Look at that. Ugh, I like this micro orthodontics. And just get it. See just the nice approximation of the surfaces there and the long axis running through there. Just so much better. Okay. Now, as far as I remember, these teeth in the bottom had to extrude. Yeah, they're coming up. So I need to make sure that the attachments are going to work. These attachments old and definitely not good enough for extrusion, so let me just ask them remove attachments on 3, 4, 3, 5 and replace with extrusion attachments. Let's see what happens with these bottom teeth. There's a lot of root movement in this canine. I've asked him to remove the button. So I'm going to ask them for a long cut to be able to get these changes there. These teeth, they move bodily, so I may expect them not to do that good. This one uprights to this side, the crown, that attachment can work for that. That tooth moves bodily, bodily movement, and this one bodily movement as well. So I'm going to take my chances on those. These teeth only changes in the buccal inclination, so I'd rather have a tight fit of the aligner on the surface there. So for that now we're going to have medial movement here. The class 3 elastic's going to do the thing here. I don't know if that attachment is big enough. I'm going to have to suffice with that. Let's just check. What I like that they did is they moved frog stage. We call it frog staging, moving teeth not all at the same time. So you can see that the 3, 4 and 3, 5 moves, and once they're into position, the 3, 6 and the 3, 7 starts. So my last point that I'm going to check here is just the cut line. My strategy with a cut line is when I start off and I have my initial cases and I have crowding, I'll have the cut line low and scalloped on the teeth on the gingival margin, just to make it easier for the patient to fit. And as I move on in my refinements, I want a much more force and a sturdy, hard force on the teeth. They align so the aligner can engage much more easily. So then I'll ask for the cut line to be extended on the gingiva. So I'm just going to check what they did here, and you can see it's scalloped there. So I'm also going to ask them, there we've got a problem. Not a problem, but let's just see. I'm going to ask them to extend the cut line to the distal of the 2/6. One millimeter onto the gingiva, buccal, lingual, anterior and posterior, and include the distal surface of the 2/7. They may get back to me and tell me it's impossible because the 2/8 was coming through there, but I think it is possible. Let's just quickly go and have a look at the case design. I think somewhere I saw that too there. No, they removed it there as well. Yeah, there you go. It's more than possible for them to extend the distal cut line onto the gingiva there. Kindly. Okay, so let's go back to the last one, my changes. And posterior, extend cut line 1 millimeter onto the gingiva, buccal, lingual, anterior and posterior, and include the distal surface of the 2/7 up to the gingiva. There we go. My computer's acting up, so let me just see what's going on. Of the 2/7, to touch the gingiva. Okay. I'm going to have to review this case again, which is sad. I want to finish it off. But then I'm going to see you guys with the follow-up again on it. Thank you for seeing me through with this case, helping me, and I hope to show you the final refinement.